Okay, so hopefully everyone's having a wonderful day. It's a little rainy and cold outside today, but you know what? That's fall in Montana. Okay, so we're going to continue our discussion of chapter 11. Chapter 11 is a very dense chapter. Today's lecture is 121 slides, so buckle up. It's going to be a long one. There's a possibility we'll see how timing goes for this. There might be a part one and part two for this just because I think it's important to not go through the mental fatigue, whether it be me as a lecturer or you as somebody watching this. So I would probably recommend about every 20 minutes, just kind of pausing the lecture that's been recorded and just like giving yourself a little mental break because we're basically going to go over a lot of the same kind of structure, like the way the structures are gone over is very repetitive because we're basically going to be saying, this is a muscle group, here's the origin, here's the insertion. Sometimes we'll be talking about innervations, but it's just going to be that kind of pattern again and again and again, very much like part one. And so I think taking breaks is important because generally the human mind can only focus for about 20 minutes. Generally, after that, everybody kind of starts to like glaze over. And trust me, I've seen it in the classroom a million times. So yeah, that would be kind of my recommendation. In terms of, I guess the first thing students are going to ask me is, what do I need to know? What don't I need to know? What do I have to pay attention to? What can I kind of disregard? And ultimately, what you'll be required to know is any muscle group that is in a table is going to be kind of up for grabs. But in terms of the origin and insertion, you don't need to know that material. So any muscle group that's in a table. So it's a lot of the major muscles. We're going to be going over a lot of them today. And then after, probably between today's lecture and Thursdays, there'll be a study guide coming out to kind of help you focus your study. Okay, so not surprisingly, it's literally just origin, insertion, innervation of muscles of the thorax, the arm, the forearm, the palm, the gluteal, the femur, the muscles that move the fibula, the femur, the tibia, the fibula, leg, foot, and then lastly, we'll talk about disorders of the muscular system, but it's gonna be a while till we get there. Okay, so kind of the rundown in terms of where we are, where we're going. Make sure you answer the study guide questions for chapter 11 before you come to class on Tuesday and Thursday. Your quiz is due Friday by midnight. Just a heads up, there is no adaptive practice due next Monday, just because we have an exam next Thursday, and also we're not going over any new material next week. So we'll be spending Tuesday basically as a review session because I feel like the skeletal system and the muscular system, there's just so much memorization that I think it's just going to be kind of nice to kind of maybe just spend that time focus on that memorization and not necessarily acquiring new material. And it kind of creates a nice bookend to this section of the class because we focus primarily on just bones and muscle stuff. And then the next kind of last third of the class will be focused on the nervous system. Yay. And then the other thing to note that's a little different this week is that the pro section 2 is due on Friday. I think there are 4 parts to the pro section, and it's literally just, arrows pointing to muscle groups. I tried to choose muscle groups that we'd be discussing in class that you'd be responsible for knowing. And so there are 4 different parts to the pro section on Wiley Plus. So please make sure that you're going on to Wiley Plus and checking out those assignments. Okay, so muscles of the abdomen that protect the abdominal viscera and move the vertebral column. So we have the anterior lateral abdominal walls composed of skin, fascia, and 4 pairs of muscles. And so these are all muscles that are located within the abdomen that are very important for protection and movement of that region. So if we look at the muscles of the abdomen, this is a nice, wonderful picture because it doesn't make everything seem too intimidating, right? So let's go ahead and start kind of circling the big muscle groups that you'll definitely need to know. So it's also worth kind of pointing out things that you probably have, studied in the past. Things like the clavicle, the scapula, and these are bones. These are going to be insertion points and origins for some of these muscle groups. But again, hopefully you feel very comfortable with those bones because those are going to be things that will be on the exam. So up here, you've got your deltoid, kind of part of your shoulder that's going to be important for that muscle group. You have your pectoralis major, again, another major muscle group. Remember when we were talking about different types of muscle shapes, this is a great example of that kind of fan shape that we talked about. When we get to the upper arm, we'll talk about the biceps brachii. And then underneath that, you can kind of see the latissimus dorsi, the serratus anterior. Now, these are not all necessarily going to be gone over just at this moment when we talk about the muscles of the abdomen, but we will hit a lot of these muscles at some point. You have your rectus abdominis, your external oblique, kind of, outside here on the side of your body. And then if we kind of do a cross section and cut in, you can see that here, the anterior deep view. So this is superficial, meaning more towards the skin. The deep view is where we're kind of cutting away this first layer here, and then layered underneath that, you can see this other group of muscles. So it's interesting because there's different, orientations of the muscle groups. It allows for a lot of different movements in a lot of different directions, given you've got some superficial and some deep that are mediating these different movements. Serratus anterior. So remember when we talked about different types of muscle shapes, remember when we talked about the serratus being like a serrated, I think of a serrated knife, kind of jagged an edge. So the serratus anterior, you have your external oblique, and here you can see that it's kind of cut away. And then you have your rectus abdominis located here, your transverse abdominis located here, and then your internal oblique. So recognize that you have both external and internal oblique. And so a lot of these other things, you're seeing things like, your alba, your ligament, your intersections. These are just other descriptive words to kind of paint a picture of exactly what you're looking at here. But anything that I've kind of circled or kind of annotated in red is kind of essentially up for grabs. And don't worry, don't freak out, because we're going to be going through these muscle groups multiple times on different slides. And so you'll probably get tired of the names of them by that time. Okay, so we'll start with the rectus abdominis. So the origin is the pubic crest and the pubic symphysis. So if we go back here, you can see the pubic symphysis, the tubercle, and the rectus abdominis again is right here. And you can see it kind of extending up into the superior, from the inferior to superior region. The insertion is a cartilage of the ribs of 5 to 7 in the xiphoid process. So just kind of right below your sternum, and flexes the vertebral column, especially the lumbar portion. So all of your lower back motions, and compresses abdomen to aid in defecation, urination, forced exhalation, and childbirth. RMA is the flexes the pelvis on the vertebral column. So in terms of its innervation, it's getting its nerves that are extending out from the spinal column from the thoracic spinal nerves T7 through T12. So rectus abdominis, you need to know that muscle. You need to know the origin, insertion, action, or innervation. No, that's just for your general knowledge. But again, if you are going pre-PT, maybe getting just kind of an introduction now, and then at some point when you go and take a higher level anatomy and physiology class, you'll be like, oh, I remember that being mentioned. Okay, your external obliques. Oh, I kind of wish that we could go back and look at the picture every single time. So here's your external obliques, and here you can see that they're cross-section and they're actually cut. Okay, and so your external obliques, the origins are going to be ribs 5 through 7. Their insertion is going to be the iliac crest and the plana albia. So again, think down near your hips. They act together to compress the abdomen and flex the vertebral column, acting singularly or unilaterally. Laterally flex vertebral column, especially the lumbar portion. Again, lower back, kind of getting that motion. And then your innervation is the thoracic spinal nerves, T7 through T12. Okay, and the iliohypogastric nerve as well. So some fun words there. The internal oblique, and so we just went over the external, so let's go back to the internal. I should just cut and paste this picture on every single slide. Here's your internal oblique. Ooh, so it's right there. You can see the internal oblique. Your internal oblique. Okay, so your origin again is the iliac crest, the integral ligament, and the thoracolumbar fascia. The cartilage insertion is the cartilage of the ribs 7 and 10 in the linea alba. Its action, acting together, is to compress the abdomen, flex the vertebral column. Acting singularly, it can laterally flex the vertebral column, especially in the lumbar portion. Hopefully you're recognizing a repetitive kind of action here, and rotate the vertebral column. I'm basically doing these motions to help keep you engaged. Thoracic spinal nerves T8 through T12 and the iliohypogastric nerve and the ilioinguinal nerve as well are going to be the nerves that innervate that region. And so again, we'll use things like vascularization and innervation often. Vascularization is how basically the blood supply is integrated to a region. And we talked a lot about that when we talked about tissues. Innervation is how the nerves are integrated into a muscle group. And again, the nerves are integrated into that muscle group. They're going to release neurotransmitter and cause that muscle group to contract. And so it's basically how your brain is interacting with that muscle group to cause the movement. And so the reason we're interested in innervation is because if there's damage, let's say let's say the T8 to T12 area, this is one of the muscle groups that would possibly be affected by that damage. And so you might ask yourself, why do we care about innervation? That's one of the reasons. Also, if you're having any kind of issue, neuromuscular issue, meaning like the interaction with your nervous system and your muscular system, that's one way you can also treat that in a very targeted way, which maybe we'll talk about when we talk about disorders. Okay, the next muscle is transverse abdominis. We'll go back and look again. Transverse abdominis is right here. We can see that cross section. It's kind of, hard to see because there's so many different cross sections that we're looking at here. But again, the transverse abdominis is kind of in the lower abdomen region, the inferior abdomen region. Okay, so the origin is the iliac crest. You're again recognizing a lot of origins of muscles in that region. An equal ligament, lumbar fascia, and cartilages of the ribs 5 through 10. Your insertion is going to be your xiphoid process, which is at the very base of your sternum, your lineal alba, and the pubis. And so again, that's kind of just all down your mid-sagittal region. The action of the transverse abdominis is to compress the abdomen, and in its innervation is thoracic spinal nerves T8 through T12, iliohypogastric nerve, and ilioinguinal nerve. So again, innervation telling you where the nerves are kind of coming out of the spine to innervate that particular transverse abdominis region. Okay, quadris laborium. So I guess we'll go back. Boom, 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 boom. Okay, so the transverse, did we do it? Transverse abdominis? Yes. Quadratus laborium. That's what we're looking for here. Quadratus laborium. I don't know if it's labeled on this particular. Maybe it's not labeled on this guy. Okay. So, okay. So again, its origin is going to be the iliac crest, iliolumbar ligament. It's inferior to the border of the rib 12 through L1 through L8. And its action is to act together, pulling the 12th rib inferiorly during forced exhalation. Fix 12th ribs to prevent elevation during deep inhalation and help extend lumbar portion of vertebral column. Again, thoracic spinal nerves T12, lumbar spinal nerve L1 through L3, so very much in the lower part of the spine is going to be where those nerves are going to come from the spine and innervate. What's really interesting is when we get to talk about the peripheral nervous system, we've talked about the different bones that make up the spinal column. Obviously, you have your cervical, your thoracic, your lumbar, your sacral. So what's interesting is you have a spinal cord that runs through the entirety of each one of those regions, and you can actually look at the cross section of the spinal cord and be able to tell where that innervation is going to go. So hopefully when we get to the peripheral nervous system, we'll be chatting about that. Okay, so let's continue to move on. These are going to be the muscles of the thorax that assist in breathing. So we just talked about a few of the muscles kind of in the lower abdomen region that are important for things like forced exhalation. But we're going to continue talking about some muscles that assist in breathing. So muscles of the thorax, again, this is going to be the region right around your rib cage that's protecting your lungs, but all of those muscles are going to assist in the inhalation and exhalation of oxygen, which is important for obviously taking oxygen into our body, to oxygenate all of our tissues, including the muscles, to make sure they can live and sustain life. So it's very important that these muscles function. Any dysfunction in these muscles could cause major cardiovascular issues for an individual. So the muscles of the thorax alter the size of the thoracic cavity, so breathing can occur. So it allows you to expand and contract your thoracic cavity, so the inhalation, exhalation of your lungs can be facilitated. Okay, so muscles of the thorax. Here you have your internal intercostals. And so anytime you see intercostal, think of between the ribs. Here you have your external intercostals. Again, these are outside kind of that rib area. We can see things like the pectoralis minor that's been cut. You can see that here, your external oblique, kind of running down the side of your body. Transverse abdominis we covered last time. Oh, we've mentioned the linea alba a few different times in terms of origin and insertion points. So I'm just going to point that out really quick. That's kind of that midline that you see there. Inguinal ligament, we've also talked about that. Again, we talked about the iliac crest and insertion an origin point. Obviously, these are all the ribs here that are extending out. You have internal intercostals, your innermost intercostals, and so this is kind of a cross section of that. You can kind of see that lining just the very inside of those ribs. We're going to talk about the diaphragm quite a bit and some fun stories about the diaphragm. It's that muscle that's located kind of right underneath your rib cage that kind of really helps the breathing process happen. It's one of the most critical muscles in your body for breathing to occur. And then we'll talk about your quadratus labiorum. Again, that's kind of inside the thoracic cavity as well. Some of the other, you should feel pretty confident about some of the other labels that are included here because we've talked about them in the past. Things like the clavicle or the iliac crest or the sacrum or the pubic symphysis. All of those things are things that we have discussed in other chapters. And again, they're just kind of being used as points of reference here to kind of give you a sense of where some of these muscles are originating and inserting. Again, there's obviously this deep connection between bones and muscles, and so those bones are being kind of the anchors for these muscles in a lot of ways. Okay, so muscles of the thorax. So this is essentially a superior and inferior view of the diaphragm. So you can see here the diaphragm, like I said, is a very important muscle that's located just kind of underneath your rib cage that's important for inhalation and exhalation. So the diaphragm, we'll see, is located here. Diaphragm is located here. This is a nice cutaway. There's some pleural that's cut away here, so you can actually see the musculature of the diaphragm. If we cut away all that pleural, we can see here the nice diaphragm. The vagus nerve is going to be the nerve that innervates right here, that causes the diaphragm to contract. Now, the diaphragm and the muscles of the diaphragm is probably one of the muscles that is one of the most active muscles. And the reason I say that is because of this quick story I'm going to tell you. I studied botulinum neurotoxin, which is essentially the toxin that's made by Clostridium botulinum. So if somebody got botulism, this would be the toxin that they would be suffering from. Now, because the diaphragm is the muscle that kind of works the hardest in our body, it's the first muscle that undergoes paralysis with botulinum neurotoxin. And so because of this paralysis, individuals who have that who've been exposed to that toxin, they are unable to breathe. And so respiratory distress is actually one of the first signs of botulism. And so one of the treatments for it is also the respiratory treatment of being treated with a ventilator. And so if there was ever like a mass outbreak of botulism, that probably would be like the most limiting factors. You'd have to have enough respirators for people to sustain life, because eventually the botulism will go throughout your entire body and cause a flaccid paralysis for your entire body. But it's the effect that it has on your diaphragm that is probably the most life-threatening, just because this particular muscle is so important for breathing. And so again, that's just kind of a quick side note, but it does kind of lend you to the idea of how important the diaphragm is and how often you use the diaphragm. Probably one of the muscles that you use the most frequently. I mean, I'm right now watching myself blink, and so the muscles that we talked about for blinking, but again, this is one that is not just important because of high usage, but it's also important because of its function to aid in breathing. So that's not necessarily an anatomical description of the diaphragm, but it does, again, kind of give you a good understanding of why it's so important, again, and it's contracting and relaxing. And in the lab that I used to work in, we actually used to dissect out the diaphragms and And that's how we would study them, is to treat with them with botulism and then try to give them drugs to recover the contraction after they've been given botulism. Had some really exciting leads, and again, super nerdy stuff. If you're interested in talking about it, more than happy to do that. Okay, so the diaphragm. The origin is going to be the xiphoid process of the sternum, so you're recognizing that there's a lot of muscles that are kind of being tethered to that region. The costal cartilages of the adjacent portions of the ribs 7 through 12, the lumbar vertebrae, and their intervertebral discs. Its insertion is the central tendon, and then for its action, the diaphragm causes a flatten and increased vertical dimension of the thoracic cavity, resulting in inhalation. Relaxation of the diaphragm causes to move superiorly, and resulting in exhalation. So literally, this is the muscle that's allowing you to breathe in, breathe out. So that's your diaphragm. Super important. Yeah. Its innervation, the phrenic nerve, which contains axons from cervical nerves C3 through C7. So yeah, we used to dissect out the diaphragm, make sure we have the phrenic nerve attached, and then we would actually stimulate the phrenic nerve to make the diaphragm contract outside of the animal. Very interesting, weird stuff. Okay, continue our conversation. So intercostals. So whenever you hear the word intercostal, think of the ribs. Well, and that should hopefully give you at least kind of a first jump as to where you might be finding this muscle group. So external intercostals are inferior border of the rib above, is where the origin is. The insertion is the superior border of the rib below. Its action elevates ribs and increases the anterior, posterior, and lateral dimensions of the thoracic cavity. That's a fun way of saying that. Inhalation expands your chest, and relaxation depresses the ribs and decreases the lateral dimensions of the thoracic cavity, resulting in exhalation. So again, these are other muscles that are very important for inhalation and exhalation. External intercostals are going to be on the outside of the ribs. Thoracic spinal nerve, T2 through T12 are going to be the innervations. Okay, so a couple the muscles of the thorax that are important for breathing: the diaphragm, the external intercostals, and then the internal intercostals, which I don't think we just covered. And those, again, think of inside the ribs, internal intercostals. The superior border of the rib below is going to be the origin. The insertion is the inferior border of the rib above, so basically between the ribs. If you're an animal, this is a delicious part of your body. Sorry, it's kind of random, but the contraction draws ribs together to further decrease the anterior posture and lateral dimensions of the thoracic cavity, forced during exhalation. So again, important for inhalation and exhalation. Okay, intercostals, diaphragm, important for breathing. Okay, muscles of the pelvic floor that support the pelvic viscera and function as sphincters. Okay. I'm actually going to just not go over the pelvic floor stuff. We're just kind of omit that. And so we're going to move on to the muscles of the thorax that move the pectoral girdle. So muscles that actually move the pectoral girdle. So if we look at that, we've seen an image like this very similar when we're talking about the back and the lumbar. I'm sorry, the muscles of the back. So here's your levator scapulae, here's your trapezius being kind of right that part of your, one of your muscles that kind of allows you to shrug. Let's see what other, we have your pectoralis minor, your serratus anterior, and again, it's got that nice serrated edge to it. The serratus anterior from another angle, and your levator scapulae from a different angle. Here you can see a cross section of your rectus abdominis, which we just discussed. And then we just also discussed your external and internal intercostals. So hopefully you're taking heart in the fact that a lot of these muscle groups we've kind of discussed, and there's a lot of overlapping function of them between what we're talking about. The other thing that I want to point out is that the other kind of labels that you see on this image, things like the clavicle or the humerus, or the ribs or the sternum or the scapula or the other rib, those are all bones. Hopefully you feel very comfortable with those bones, but it also kind of allows you to put these two different chapters into context and see the relationship with one another, but it also allows you to review the old material. So when it comes test time, you'll be like, oh, I saw this material not just in chapter 8, but then I also saw it again in chapter 11. It's all coming together now. Okay, so muscles that move the pectoral girdle. So you have your subclavicus, which your origin is rib 1, your insertion is the clavicle. So again, that kind of gives it away there. This action is depresses and moves the clavicle anteriorly and helps stabilize the pectoral girdle. The subclavian nerve is going to be that. So if we go back to this image, we can see the subclavicus right here. So again, you can see it's nice interaction right there with that first rib and that clavicle. So yeah, I should just put this image on every single one of these slides. And then we have the pectoralis minor, ribs 2 through 5, 3 through 5, 2 through 4. The insertion is the corticoid process of the scapula. And the action is that it abducts the scapula, rotates it downward, and elevates the ribs 3 to 5 during forced inhalation when the scapula is fixed. And then its innervation is the medial pectoral nerve. So if we want to look at the pectoralis minor, let's go ahead back and look at the pectoralis minor. Here you go. And you can see 3, 4, and 5, and then the corticoid process of the scapula, and then its interaction with the ribs down here. So it kind of gives you a nice example of kind of where, it's interesting with that fanning motion, it looks a little serratus, just those finger-like projections. And again, we talked about different kind of muscle arrangements in our last lecture. Okay, and then we have our serratus anterior. Again, our serrated muscles. Its origins are rib 1 through 8. Its insertion is a vertebral border of the inferior angle of the scapula, and the action is abducts the scapula and rotates it upward, and then elevates ribs when scapula is stabilized, known as the boxer's muscle because it's important in the horizontal arm movements such as pushing and pushing. So serratus anterior, important for those motions. And it's the long thoracic nerve that innervates that. And so we'll come back here, the serratus anterior, right here. I should put a different color because these muscles are red. Here you see kind of that region there. So the serrated muscles, and it's nice because it's on both the anterior deep view and the anterior deeper view that is over here. Excuse me. There you go. Okay. So a couple different examples of where that muscle group is found. Okay, trapezius. I'm sure you've heard that person has big traps. Superior nuchal line of the occipital bone back here. And then your clavicle and acromion spine of the scapula. The action is superior fibers upward rotate scapula, midline fibers abduct scapula, inferior fibers depress, superior and inferior fibers together rotate scapula upward, stabilizes scapula. You can see that there's a very close interaction here with scapula. Superior fibers can help extend head. Accessory nerve 11 and cervical nerves C3 through C5. Okay, so your trapezius is right here. You know, you can get huge muscles in the trapezius region. Okay, so the levator scapulae, transverse process of the C1 through C4, the superior vertebral border of the scapula elevates the scapula and rotates it downward. The dorsoscapular nerve and the cervical nerves C3 through C5. And so we're going to go back and we'll look at the levator scapulae and the rhomboid major, which is the origin of spines T2 through T5. The insertion is a vertebral border of the scapula inferior to the spine. It elevates and abducts the scapula and rotates it downward, stabilizes the nerve, and the dorsal scapular nerve is its innervation point. So let's look at levator scapulae and rhomboid major. Levator scapulae, you can see that one right there. And I don't think rhomboid major is on this particular yeah, I don't think it's present here. Okay. Well, yeah, but you still get kind of that understanding of where the levator scapulae is, its origin and insertion points, and how important it is for that upper part of the thoracic cavity. Okay, rhomboid minor, spines of C7 through C12. The vertebral border of the scapula to superior spine elevates an adducts scapula and rotates it downward and stabilizes the scapula. Its innervation is a dorsal scapular nerve. I didn't see rhomboid major. I don't see rhomboid minors. It's a C figure 1115C. I'm guessing that's not what this particular figure is. So maybe I'll have to find that. And so in the study guide, then we can have those present easier to label. Okay, muscles of the thorax and the shoulder that move the humerus. The humerus. Okay, so again, if we're going to strip away all these muscles, we'd recognize that the humerus is going to be the long bone that's located in the upper part of the arm. And then if we look at many of the muscles that are important for the moving the humerus, we've got the deltoid, the supraspinatus, the subscapularis, the cordobrachialis, the pectoralis major, the teres major, latissimus dorsi, we'll get a little far down here. Pectoralis major, we already kind of saw before. Again, it's kind of cut in its cross section here. The pectoralis minor is also located here. The serratus anterior, which we just saw on that last set of tables. Let's see, we've already gone over clavicle, subclavicular, serratus anterior. We've already talked about that. And then since we're talking about the humerus, we probably, the biceps brachii, we'll be hitting that a little bit later, but it's important to recognize that it's all kind of located in this general region. Okay, so now we're going to go through our tables and kind of flip back and forth between the table and this image. Okay, so that's the interior view. Let's look at the posterior view. Again, you're looking at the back from this angle. And so you have your supraspinatus kind of located in this region here, your infraspinatus, your teres minor, right kind of in that location there. Your rhomboid major, we were talking about that not too long ago. Your teres major, recognize wherever you see a major, there's probably a minor. So we saw teres major, there's probably a teres minor. You have your triceps brachii, and then your latissimus dorsi. Again, that's kind of a big swath of muscle that covers the lumbar area of your back. Your coracobrachialis, your teres major, and your deltoid in this general region here. And again, here's your rhomboid minor and your levator scapulae. Again, recognize that some of these are cutaways, but they're important nonetheless in this movement of the humerus. If you think about the movement of the humerus, it's not going to be just the anterior muscles, but you're going to have your posterior muscles as well that are going to coordinate the movement of that particular region of the body. Okay, so lots of good labeling on that one. Okay, pectoralis major, very clear, apparent, obvious kind of, I guess, muscle. Do we have? Oh, I was hoping that we had kind of just said picture of the whole pectoralis major kind of just coming across the chest, because here it's cut away, so it doesn't look, I think, as impressive. But again, the pectoralis major is going to be right here, and again, it's been cut away. But normally you'd have just one big, large muscle group kind of extending across the chest. People often call them their pecs. Yeah, not shockingly, pectoralis major, they're your pecs. The origin is the clavicular head and sternum and the costal cartilages of ribs 2 through 6. The greater tubercle and lateral lip of the intertubercle sulcus of humerus. Its action adducts it medial rotates the arm and the shoulder. Its innervation is the medial and lateral pectoral nerves. Latissimus dorsi, again, a very large muscle group located on the anterior side of the body. I'm sorry, the posterior side of the body. Its origins are spines T7 through L5 and crest of the sacrum and the ilium, ribs 9 through 12. The insertion is the intertubercular sulcus of the humerus. Again, this is basically what we're talking about, is muscles that move the humerus. And then its action extends, adducts, immediately rotates the arm at the shoulder, draws arm inferiorly and posteriorly, elevates the vertebral column and torso, and the thoracodorsal nerve is going to be the nerve that innervates the latissimus dorsi. Okay, the deltoid. So the acromonial extremity of the clavicle, acromon of scapula, and spine of scapula. The insertion is the deltoid tuberosity of the humerus, and the action lateral fibers adduct the arm of the shoulder joint. Anterior fibers flex and medially rotate the arm of the shoulder joint. Posterior fibers extend and laterally rotate the arm of the shoulder joint and the axillary nerve. So we just went over the deltoid, the latissimus dorsi, and the pectoralis major. So if we're going to go back and kind of look at this image, here you see that big latissimus dorsi. That's one of the muscles that we just talked about. And then the other one muscle we just talked about was the deltoid that you can see here. They're very apparent and large muscle groups as part of the posterior view. And then again, if we just quickly go back to the anterior view, your pectoralis major is going to be that pec. Okay. Subscapularis, subscapular fossa of the scapula. Insertion is lesser tubercle of the humerus. Its action immediately rotates the arm at the shoulder joint. Its innervation is upper and lower subscapular nerve. Supraspinatus is a supraspinatus fossa of the scapula, the greater tubercle of the humerus. Assistance in deltoid muscles in abducting the joint at the shoulder joint. And then the subscapular nerve. So the subscapularis and supraspinatus. So let's go ahead and check out where those are. You can see the supraspinatus here. And then let's see, I think we're gonna have to go back to the other one. And supraspinatus is also located here, and the subscapularis is located here. So you can kind of draw that into this general region here. And supraspinatus is going to be like just inferior to the deltoid. So smaller muscle groups than maybe some of the other ones we just talked about, but still important nonetheless. Some of them have assist in many of the motions that the other ones are going to complete. Infraspinatus is the infraspinatus fossa of the scapula. Its insertion is the greater tubercle of the humerus. Its action is to laterally rotate the arm with the shoulder joint. Innervation is a subscapular nerve. Teres major is origin is the inferior angle of the scapula, the medial lip of the intertubercle sulcus of the humerus. And its action is going to be to extend the arm at the shoulder joint and assisted adduction and medial rotation of the arm at the shoulder joint. The innervation is the lower subscapular nerve. So infraspinatus and teres major. Infraspinatus and teres major. So here's your teres major. Right here, you can see those interaction with the scapula there and the humerus. And was it infraspinatus, I believe? Yeah, infraspinatus. And you can also see kind of that general region. It's hanging out there. So teres major, infraspinatus, again, going to assist in many of the arm motions for the humerus. Okay. Teres minor, so like I said, where there's a major, there's usually a minor. The infralateral border of the scapula, the greater tubercle of the humerus, laterally rotates and extends arm joint. And the axillary nerve, coracobrachialis, coracoid, process of the scapula, middle of the medial surface of the shaft of the humerus, flexes and abducts the arm at the shoulder joint. So teres minor and coracobrachialis. Boop, 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 boop. Okay. So you have teres major, teres minor. See various kind of small muscle group right there. And then we have coracobrachialis kind of located kind of under the arm there. I don't want to say difficult to see from this angle, but again, there's a slightly smaller muscle group, so you kind of have to see past some of those other larger muscle groups to kind of see them. Okay, muscles of the arm that move the radius and the ulna. Okay, so radius and ulna. So let's not get too crazy here. There's a lot of labeling, but things like the clavicle, the scapula, the humerus, all bones. Don't need to know those right now. Well, need to know them, but not new material. Tendons of the latissimus dorsi are cut here. Tendons of the pectoralis major are cut here. The deltoid are also cut here. So you can kind of see cross sections of muscle groups that would normally be, covering the this area here. Here's a great image of your teres major. Again, with all those other larger muscle groups that are removed, you can kind of see that particular muscle group a little bit more apparently. And then you have your biceps brachii, your biceps. I mean, again, some of these words are very common nomenclature, so you don't have to do a ton of memorization. Biceps brachii. And then your brachialis are kind of located more towards the joint. You can see that cross section there. And then here's your aconius, just kind of located back there behind your elbow joint. And we're going to also talk about your triceps brachii, so your triceps and your biceps, triceps on the back side, biceps on the front side. And yeah, so we'll just talk about these muscles as their function of moving the radius and the ulna. Okay, so let's say we're going to take a transverse plane right here, like where the middle of your bicep, and this is how those muscle groups would essentially look. So you can look down kind of that cut, and you'd have your biceps brachii on that front side, your triceps brachii back here on your back side, your triceps brachii, your lateral head, your long head, your triceps brachial medial head. So you can see that those triceps are kind of broken down into those three regions. Your brachialis, again, is going to be located right on the inside kind of interior portion. Right on the kind of outside of the arm there. And then you have your biceps brachii, your short and long head represented there. So you've got your triceps brachii, both lateral, long, and medial heads, your biceps brachii, your short head and long head, your brachialis, which kind of runs on the outside of your arm. And then you also can see things like your humerus and then your nerves that are going to be innervating these regions to allow for movement. Okay, so this image is nice because it pulls away all of those different muscles and allows you to focus just on a single muscle group if it were attached to, the humerus and the ulnus and the radia. The brachialis you can see here in the first image, brachioradialis in that second image, acondus and supinator are in this third image, and pronator teres and the pronator quadris. Again, these are going to be important for movements of the radius and the ulna, and then they'll also kind of play a role get to talking about movements of the hand. Okay, biceps brachii. So I've seen the biceps brachii in a couple different orientations, so hopefully you feel pretty visually comfortable with that. And again, it's one of those muscles I think that people hear about regularly, and so you kind of have, I think, a pretty clear idea of like where that muscle group is on your body. So the long head originates from the tubercle above the glenoid cavity and the scapula, and then the short head originates from the corticoid process of the scapula. The insertion is the radial tuberosity of the radius in the bicipital aponeuroses, and then the action is to flex the forearm at the elbow joint, supinates forearm at the radial-ulnar joints, and flexes arm at the shoulder joint. And the muscular cutaneous nerve is the innervation. Brachialis is the distal anterior surface of the humerus. Its insertion is the ulnar tuberosity of the coordinate process of the ulna. Flexes forearm at the elbow joint. The muscular, cutaneous, and radial nerves are going to be the innervations for brachialis. Brachioradialis is the lateral border of the distal end of the humerus, superior to the styloid process and of the radius, flexes forearm and elbow joint, and the innervation is going to be the radial nerve. I did not mention that it also pronates and supinates the forearm at the radial-ulnar joints to the neutral position. I know this seems like a lot, and again, I'm basically giving you a lot of extraneous information because you do not need to know origin and insertion. You just need to know the muscles where they're located on the body. But sometimes origin insertion can give you a heads up as to where to start looking. Okay, triceps brachii, long head, originates from the infralegonoid tubercle, a projection inferior to the glenoid cavity of the scapula. We know where the glenoid cavity is. The lateral head originates from the lateral and posterior surface of the humerus. The medial head originates from the entire posterior surface of the humerus inferior to the groove or the radial nerve. The insertion is the acronon, olarcanon of the ulna, and the action is to extend the forearm at the elbow joint, at the shoulder joint. And its innervation is the radial nerve. Aconius is the lateral epicondyle humerus, extends the forearm at the elbow joint, and then its innervation is the radial nerve. So again, we've slowly but surely worked our way through all of these muscles that are shown on this particular image. Okay. Pronator teres, it is going to be the origin is the medial epicondyle of the humerus and coronate process of the ulna. Its insertion is the mid-lateral surface of the radius. Its action is to pronate forearm at the radio-ulnar joints and weakly flexes the forearm at the elbow joint. And its innervation is the medial nerve. Pronator teres. So see this little guy down here? Ooh, ooh, ooh. It's going to be your pronator teres. And then we're going to probably go over the pronator quadris next. Yep, there we go, pronator quadris. So it's a distal portion shaft of the ulna, which we just saw. The distal portion of the shaft of the radius is its insertion. Its action is to pronate the forearm at the radio-ulnar joint, and its innervation is the median nerve. Okay, so the supinator, forearm supinator, the lateral epicondyle of the humerus in the ridge near the radial notch of the ulna. Its insertion is the lateral surface of the proximal 1/3 of the radius. Supinates forearm at the radio-ulnar joint, and deep radial nerve is the innervation. So if we go back, oops, supinator, supinator. Here we can see it. It's located near the condyles. Supinator, right there. Okay, so think of it as part of one of those important muscles to move the radius and ulna. Okay, so we're slowly but surely working our way through the thoracic cavity down to the humerus, the radius, ulna. Now we're going to go muscles that move the forearm, move the wrist, hand, digits, and thumbs. So as you'll probably expect, there's going to be a lot of small muscles in this region, just because one, it's a small region, but you do so many fine movements with your fingers and hands that there's has to be a lot of muscles there to be able to facilitate all that fine movement in so many different directions. Okay, so again, some of these muscles we just saw, so do not get overwhelmed. So we actually just talked about the supinator. We just talked about the pronator teres. We talked about the brachial radialis. We had not talked about the palmus longus, the flexor carpi radialis, the flexor carpi ulnaris. We'll also talk about the extensor carpi radialis longus, the flexor digitorum superfallacius, the flexor pollicis longus, and the pronator quadris. This is just a different angle where we're looking at many of the same muscles we just said. Flexor digitorum profundus is maybe one that we didn't hit from this other angle. But yeah, you can see here all of these muscles that are having their origins and insertions very much into the phalanges and such. And so here you can see many of the tendons that are being the tendons that are being utilized to move the hands themselves. So again, some of these muscles are new. Many of them we just talked about. Okay. So if we look at the posterior view here, you can see the extensor carpi radialis longus, extensor carpi ulnaris, extensor digitorum, extensor carpi radialis brevis, the flexor carpi ulnaris, the abductor pollicis longus, which we just talked about, extensor pollicis longus from a different kind of the abductor, and then the extensor indicis, the extensor digimenium, the extensor pollicis brevis, all kind of, again, located right there inside the posterior deep view. Okay, so again, if we do kind of that transverse plane, we're cutting right there at the base of the hand. We're looking at innervation, not just innervation, but looking at the muscularization of those regions. Here you can see those bones that we've learned, right? Pisiform, tracheum, hamate, capitate, trapezoid, trapezium. Again, hopefully all those words look very familiar to you. You're like, oh, I got this. But then you can see that there are a series of different tendons that are running into that region. Your flexae retinaculum is going to be located right here on the anterior part of your palm, and your extensor radiculium right there. You've got a synovial sheath all around the region here. Again, it's going to be kind of enclosing all of those tendons. And so if we look at those tendons that are running kind of right inside there, you'll see that they're numbered in this region. We should circle. They're numbered right here. This is what I'm talking about. And those numbers are going to correlate to the components of the carpal tunnel. So you've heard of carpal tunnel syndrome. So here, 1 is going to be the medial nerve. 2 is going to be the tendons of the flexor digitorum, superficialis muscles. 3 is going to be the tendons of the flexor digitorum profundus muscles. And then 4, I need to erase this so I can actually see the numbers. And then 4 is going to be the tendon of the flexor pollicis longus muscles. So you can see those tendons of each of those muscles is kind of, allowing for the movement of those hand muscles and how important it is for them to be encased in that synovial sheath. And again, overuse of some of those can lead to things like carpal tunnel syndrome, which I don't know if we'll talk about that when we talk about diseases of the muscular system. We'll see. Okay, so first we have the flexor carpi radialis. Its origin is the medial epicondyle of the humerus. It's going all the way up there. The metacarpals 2 and 3 and flexes and abducts the hand. Radial deviation at the wrist joint, and its innervation is the medial nerve. So flexor carpi radialis. Let's see if we can find flexor carpi radialis right here. There you go. That little muscle right there. Oops. Okay. Okay. Palmaris longus is a medial epicondyle of the humerus. Its insertion is flexor retinaculum and palmaris hypertenosis. Flexus hand at the wrist joint. Its innervation is the medial nerve. The flexor carpi ulnaris is a medial epicondyle of the humerus and superior posterior border of the ulna. Its insertion is the pisiform hamate base of metacarpal 5, and its action is to flex and adducts the hand via the ulnar deviation at the wrist joint. Its innervation is the ulnar nerve. The flexor digitorum superficialis, its origin is the medial epicondyle of the humerus with the coronoid process of the ulna and ridge a long lateral margin. Its insertion is the middle phalanx of each finger. And its action is to flex the middle phalanx of each finger at the proximal interphalangeal joint, proximal phalanx of each finger at the metacarpal phalangeal joint, and the hand at the wrist joint. Its innervation is the medial nerve. And the flexor pollicis longus, its anterior surface of the radius and interosseous membrane. Its insertion is the base of the distal phalanx of the thumb, and its action is to flex the distal phalanx of the thumb at the interphalangeal joint, and it's the medial nerve, flexor pollicis longus. So again, we're hitting a lot of these different muscles that are labeled in this particular cross section. Boop, 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 boop. Flexor digitorum profundus, the origin is the anterior medial surface of the body of the ulna. Base of the distal phalanx of each finger flexes the distal and middle phalanges of each finger. The interphalangeal joints, proximal phalanx of each finger at the metacarpal phalangeal joint, and the hand at the wrist joint, and its innervation is the medial ulnar nerves. Extensor carpi radialis longus, the lateral superior condyle ridge of the humerus. Metacarpal extends and abducts at the wrist joint, and then its innervation is the radial nerve. Okay. Extensor carpi radialis brevis, its lateral epicondyle of the humerus. Metacarpal 3 is its insertion point. Its action is extend and abducts the wrist at the wrist joint. Radial nerve is innervation. Extensor digitorum, the lateral epicondyle of the humerus, the distal and middle phalanges of each finger. Extends the distal phalanges of finger at each of the interphalangeal joints. The proximal phalanx of each finger at the metacarpal phalangeal joint, and the hand at the wrist joint, and its innervation is also the radial nerve. Okay. The extensor digitorum, the lateral epicondyle of the humerus is its origin. Insertion is a tender extensor digitorum on the phalanx 5, extends proximal phalanx of the little finger, metaphalangeal joint, and wrist at the joint. The deep radial nerve. Extensor carpi ulnaris, the lateral epicondyle of the humerus and posterior border of the ulna. Metacarpal 5 is its insertion point, and extends and abducts the wrist at the wrist joint, the ulnar deviation, and its innervation is the deep radial nerve. The abductor pollicis longus, again, posterior surface of the middle radius and ulna interosseous membrane, metacarpal 1, and abducens extends the thumb at the carpal metacarpal joint and adducts the hand at the wrist joint. It's a deep radial nerve. Woof. Okay. So, extensor pollicis brevis, extensor pollicis longus, extensor indicus. I'm not going to go through all the origins, insertions, and actions. We're going to go back really quick and just kind of run through some of these. Again, we just talked a lot about the flexor carpi radialis, flexor carpi ulnaris, extensor carpi, flexor digitorum superphalos, the flexor pollicis longus. We didn't mention, I think, the pronator quadris, but again, you can see the flexor pollicis longus from a different angle, the flexus digitorum profundus, and kind of their innervation points. You can see how they extend down, and those tendons are being kind of anchored in those different regions of the hand. Now, the hand and the upper arm and the wrist, this is I feel like getting kind of into the weeds of very specific muscle groups. This might be something that I'll consider just kind of pointing out very specific muscles that you'll need to know. I'm not sure if I'll go into like the level of detail of knowing every single muscle group that need to go into the hand. So I feel like, again, we're getting a little bit specific here. And each one of these does, a very, a very specific action. Not surprisingly, again, because we have such fine motor movements that need to take place in the hand. Okay, so muscles of the palm that move the digits, the intrinsic hand muscles. Okay, so if we look at the hands themselves, there still is some musculature, not just the extension of the tendons in them. So the opponents, pollicis, the abductor pollicis brevis, the flexor pollicis brevis, you can see located that more anteriorly, abductor is a little bit more superficial, and the opposens pollicis, and then here you have your adductor digiti minimum, and your flexor digiti minimum brevis, and then your opponens digiti minimum inside. Here you can see your lumbricals kind of between each one of those fingers. And lastly, you have your abductor pollicis kind of in the more posterior view, I think would be a better angle to kind of see that particular muscle group. Hopefully that's what's next. Here's our interior view, interior deep view. So again, you can see here those first lumbrical, second lumbrical, third and fourth, again, between each one of those digits. And then if we go interior deep view, the opponens pollicums, again, this is a kind of meaty part of your hand there, your protonator quadris, which is going to be located kind of right back here. Your opponens digitorum minimum, again, is located in here, and your palmar interossi are located between kind of those parts of your hand internally, and then your dorsal interossi. Palmar being kind of a little bit farther out, your more distal, then your dorsal interossi are going to be a little bit more medial. And then look at, there's some phalanges. Like, I know that those are. Okay, so again, if we're cutting away a lot of the other muscles of the hand here, you can see the palmar interossi and your dorsal interossi, kind of where they sit on the hands. Again, I think this is kind of getting down to a level of detail that I might not require of this class, but it is good information to have. Although I think it might be difficult given our level of knowledge to kind of identify the palmar versus dorsal interossi. It's important to kind of recognize the difference in kind of the shape and size of those particular muscle groups. The palmar are much smaller in their overall kind of size. The dorsal are a little bit larger, covering a little bit more, I guess, more surface area on the hand itself. Okay, so muscles of the palm that move the digits. So your flexon, your extension, your abduction, your adduction, and your opposition are going to all be these movements of the thumb. So when we're talking about these different movements, it's important when we are referring to the action of exactly what's happening. So you have the abductor pollicis brevis, its origin, insertion, its action is going to be abduct the thumb at the carpometacarpal joint, and its innervation is the medial nerve. Apposens pollicis moves thumb across the palm to meet any finger in opposition at the carpometacarpal joint. Flexor pollicis brevis flexes the thumb at the metacarpal joint and the metacarpal phalangeal kneel joints. Abductor pollicis adducts the thumb at the metacarpal joint and the metacarpal phalangeal joints. And the abductor digitominum adducts and flexes the little finger at the metacarpal phalangeal joint. The flexor digitominum brevis flexes a little finger at the metacarpal carpal. I don't know if I can do the individual movements here. Probably should stop doing that. And the opposens digiti minimum moves a little finger across to meet the palm, to meet the thumb, at opposition at the carpometacarpal joint. Opposens digiti minimum. Lumbricals flexes each finger at the metacarpal phalangeal joints and extends each finger at the interphalangeal joints. So those are going to be the lumbricals that are located between them. Palmar interossi adducts and flexes each finger except for third at the metacarpal phalangeal joints, extends these digits at the interphalangeal joints. And I mean, as we're going through these, just recognize the median and ulnar nerves is often going to be the nerves that are going to be innervating these regions. The dorsal interossi adducts fingers 2 and 4 at the metacarpal phalangeal joints, flexes fingers 2 and 4 at the metacarpal phalangeal joints, extends fingers 2 and 4 at the interphalangeal joints. Okay, so that's the hand. Really, like I said, I'm going to probably release a much focused study guide. So I probably wouldn't get too wrapped up in all of the smaller muscles. I'd like to present the material to you, and then we're just going to kind of back off and kind of focus on, really the key things for you to take away, which might not be every single muscle in the hand. Okay, muscles of the gluteal region that move the femur. So again, we're slowly working our way through the body. We get to go to our lower extremities now. So muscles of the gluteal region that move the femur. So if we look at the kind of that region located there, we can see the iliac crest located here. And again, hopefully that's a particular point in your mind, like, oh, the iliac crest is part of the hip bone. It's that kind of top curve of the hip bone. From there, we can see there's a variety of muscles that are going to be originating and inserting into the hip muscle. So psoas major, psoas minor, quadratus lumborum, sartorius, pectineus, abductor longus, gracilis, quadriceps, vastus intermedius, vastus laterus, rectus femoris, vastus metalis, and then we'll also be hitting upon some of the femoral triangle. Again, when we talk about the femoral artery, it's just kind of located, I don't want to say really superficially. There are muscles that cover it, but it is not necessarily kind of located right as close to the bone as you would think. It's still fairly superficial. Okay, so if we look at the deep view of the muscles of the femur, again, here we can see the iliac crest of the hip bone and the tensus fasciae latae. They're located here, and the sartorius, which is located here. We'll see how that muscle really kind of extends across the leg itself. The rectus femoris here, that's cut as well. The inguinal ligament, the arbitrator externus, which is located right within here. The abductor longus. Here's the pectineus. Adductor brevis, located here. Adductor magnus, adductor longus, and again, remembering what these parts of the names mean is important because it'll sometimes help you figure out where that muscle is located. Gracilis is also kind of, again, a small muscle kind of running the inside of the leg here. And then the sartorius, again, is cut here, so you don't get the full extension of it. You can see things that might look a little bit more familiar here, things like your patella and your femur. Okay, so this is your anterior deep view. If we look at our posterior superficial view, you've got your gluteus minimus, your gluteus maximus, and then the tensor fasciae latae, which we're going to see is the point of anchoring for these particular muscles. Okay, I'm not going to go into this. I mean, it's worth kind of just pointing out the hamstrings are present here. We're looking at the posterior view, and I think we'll come back to this particular figure as we're going through these muscles within this muscle group. Okay. Ooh, okay. So what's nice about this, and it might be worth even just taking this and making it bigger on your own screen, is you can see the posterior deep views of these muscles. And what's nice about this is that they're cutting away many of the muscles and focusing on individual muscle groups. So here we see the psoas minor, the iliac crest, the iliacus, the psoas major, the pectineus, the abductor brevis. And again, these are all kind of related to the femur. So you can see them all kind of located in this region here. Here you see the rectus femoris. Again, very similar orientation to that first view, but we're seeing all of those other muscles kind of removed. Here you see the vastus lateralis, the vastus intermedius, the sartorius, the vastus medialis, and then if we continue, we can see the semitendias, the biceps femoris and long head, and the semimembraniosus, and the biceps femoris and short head located here. So these are pretty small images. I would actually like it if they were a little bit bigger. So it's definitely worth kind of taking this image, maybe blowing it up on your own PowerPoint screen and really getting into kind of where each one of these points is kind of indicating for these particular regions, because I just drew all over this particular screen, but that line I'm drawing with is so thick that sometimes it's hard to tell exactly which muscle I'm indicating. Okay, so so the psoas major. So the origin is a transverse process of the bodies of the lumbar vertebrae. The action here is the psoas major, and the iliacus is the muscles acting together to flex the hip at the thigh at the hip joint, and rotate them laterally and flex trunk on hip as sitting up from supine position. It's got to be sitting, right? Lumbar spinal nerves L2 through L3. The iliacus is going to be its origins, the iliac fossa and the sacrum, with the psoas major and the lesser trochanter of the femur. Its innervation is going to be that femoral nerve. Tensor fasciae latae, its origin is the iliac crest. Its action is to flex and abduct the thigh at the hip joint. Pisiformis, it's going to laterally rotate and abduct the thigh at the hip joint as well. Its origin is the anterior sacrum, so again, back there near the base of the spine, and the superior border of the greater trochanter of the femur. So it's not surprising that it can laterally rotate the end abducts the hip thigh. The arbitrator internus is going to laterally rotate and abduct the thigh at the hip joint. Its insertion is the medial surface of the greater trochanter of the femur. Its origin is the intersurface of the arbitrator foramen pubis and ischium. Again, it's going to be really integrated into kind of that hip bone-ish area. And then again, it's linking the hip bone with kind of that femur area. Okay. Arbitrator externus, it's laterally rotating and abducts the thigh at the hip joint. Its innervation is the arbitrator nerve, and it's the outer surface of the arbitrator membrane. Its insertion is a deep depression to the inferior to the greater trochanter of the hip. And the superior gemellus is going to laterally rotate the abductor of the thigh at the hip joint. Its origin is the scale spine, and its insertion is the medial surface of the greater trochanter of the femur. Okay. Inferior gemellus, so we just went over the superior. Here's the inferior. It laterally rotates and abducts the thigh at the hip joint. like we're seeing a lot of the same action here. And its origin is this ischial tuberosity and the medial surface of the greater trochanter of the femur. So there's a lot going on with that greater trochanter of the femur. Think of how important it is for mediating the movement of that whole area of the bone. The quadratus femoris laterally rotates and stabilizes the hip joint. Again, we've been talking about many of the muscles that we're looking at here. Things like the rectus femoris and the abductor longus, gluteus maximus, and then we've talked about the superior inferior gemellus. Adductor longus, its origin is the pubic crest and the pubic symphysis. We talked about that when we were talking about the bone structure of the hip. Its action adducts and flexes the thigh at the hip joint, rotates the thigh. The adductor brevis adducts and flexes the thigh at the hip joint and rotates the thigh. And its origin is the inferior ramus of the pubis, and its superior half of the linea aspera of the femur is its insertion point. Okay. Adductor magnus, again, adducts the thigh. Pectineus is flexes and adducts the thigh at the hip joint. Okay, so we've basically hit upon many of the muscles that we're looking at here. The rectus femoris, the arbitrator externus, the adductor longus, the pectineus, adductor brevis, adductor magnus, gracilis, sartorius. Yeah, so many of these muscles, again, are kind of interacting with the greater trochanter of the femur. We can see kind of I guess maybe a better angle. It's hard because again, these are multi-layered muscle groups that are kind of overlaying one another. So sometimes it does take a specific cutaway to be able to kind of see underneath, to see all of the different muscle groups that are located more inferiorly, or I guess deep. Deep is probably a better way to put it, not inferiorly. Okay, so muscles that move the thigh, that move the femur, tibia, and fibula. So if we do it again, a transverse cut across that region of the kind of the thigh there, the middle of the thigh, you can see the distribution of the anterior compartment, the medial compartment, and the posterior compartment. And then if we kind of break down within each one of those compartments, the muscle groups that are responsible there. So here you can see the vastus lateralis, the vastus intermedius, the rectus femoris, the vastus medialis, the sartorius, again, distributed kind of across that particular region. Here you see that femoral artery. You know, it's not necessarily super deep. It's not located right next to the bone, but you do have some layers of fat and some muscle that covers it. The medial compartment contains the adductor magnus, adductor longus, and gracilis. You see gracilis kind of has not its own compartment, but it definitely has a distinct region. Adductor longus kind of tucked right in between the sciatic nerve, and the femoral artery. And adductus magnus, again, is a much larger nerve there, or not a nerve, but muscle. For the posterior compartment, you have your biceps femoris located here, your semi-tendinous and semi-membranous, and those are going to be kind of those two other submuscle groups within the posterior compartment. Okay, so in terms of the compartment of the thigh, the abductor magnus, longus, abductor brevis, and pectineus, we'll see in section 11.2, the gracilis. Its origin is the body and inferior ramus of the pubis. The action here is to abduct the thigh at the hip joint and flex the thigh. Again, it's got that arbitrator nerve there. So in terms of the rectus femoris, basilis lateralis, basilis medius, and basilis intermedius, these are all going to be insertions at the patella, and the action is all for extend the leg at the knee joint. The rectus femoris muscle acting alone also flexes at the hip joint. Don't you wish they would group together more of the muscles like this for the action? Because I feel like a lot of them have very similar actions. And so I feel like grouping them together like this actually makes it a little bit easier. And again, not surprisingly, the innervation here is going to be the femoral nerve. The sartorius is going to be weakly flexes the leg at knee. It's a femoral nerve. The posterior compartment of the thigh is going to be the region, and the hamstring is a collective designation of 3 different separate muscles. So we have the biceps femoris, we have the semitendinous and semimembranous. The actions are all going to be to flex the knee at the joint and extend the thigh at the hip joint. They all have the same action, and they all have very similar innervations as well. So biceps femoris, semitendinous, and semimembranous. I think that transverse section that we just looked at probably was the best kind of example of looking at those different muscle groups. Okay, muscles of the leg that move the foot and toes. So I imagine we're going to go down another wormhole of many very small muscles, not as many as the hand, but a lot of small muscles nonetheless. Okay, so here we can see how they are, oriented relative to the tibia and fibula. So you have your tibialis anterior, the gastrocnemius, the fibularis longus, the soleus, the extensor digitorum longus, the flexor digitorum longus, the fibularis brevis, the fibularis tertius, and the extensor hallucis longus. And then you can also see kind of the extensor hallucis brevis, extensor digitorum brevis as well. And so you're checking out all of these muscles in relation to both the tibia, the fibula, as well as all of the tarsals and metatarsals as well. Okay, that is the anterior. Here's the posterior view, where we're looking at the gastrocnemius, again, probably more commonly known as your calf muscles. Your soleus, again, is cut away here. You're not necessarily seeing the extent of that. Tibialis posterior, the fibularis longus is also here as well as the flexor digitorum longus and the flexor hallucis longus and the fibularis brevis. Now, what's nice is that they've pulled out each one of these muscles so you can see them individually, so it's not necessarily difficult to kind of discern each one. So your tibialis anterior, your extensor hallucis longus, your fibularis are present on this one. Your extensor digitorum longus is also kind of, again, present. It's, I think, a much thinner muscle than you would expect. Your fibularis longus, again, kind of located there at the posterior, kind of back where your calf is. Your fibularis brevis is kind of located more down near your ankle, interacting with your calcaneus. Your gastrocnemius, again, part of those calves. Soleus is kind of that upper part. Posterior, tibialis posterior, and then kind of deeper to that is pollicis, and then your flexor digitorum longus and your flexor hallucis longus as well. Okay, so the anterior compartment of the leg, the tibialis anterior, again, it's dorsiflexes the foot at the ankle joint and inverts supinates the foot at the intertarsal joint. So think of kind of what that action looks like. Maybe do it with your own foot. The extensor hallucis longus, again, dorsiflexes the foot at the ankle and extends the proximal phalanx of the great toe at the metatarsal phalangeal joint. Now, again, as we're describing this, try to think of what that action looks like in your head and see if you can complete it with your foot, because that'll kind of help you, again, think of what muscles are kind of moving in that region. Okay, extensor digitorum longus dorsiflexes the foot at the ankle and extends the distal and middle phalanges of each toe at the interphalangeal joints and the proximal phalanx of each toe at the metatarsal phalangeal joint. And the fibularis dorsiflexes the foot at the ankle joint and everts, pronates the foot at the intertarsal joints. Next, we'll talk about the lateral fibular compartments of the leg. So fibularis longus. This plantar flexes the foot at the ankle joints and everts or pronates the foot at the intertarsal joints. And the fibularis brevis is the plantar flexes joint and the ankle foot at the intertarsal joints. Gastrocnemius, plantar flexes foot at the ankle joints and flexes the leg at the knee joint. And soleus, plantar flexes the foot at the ankle joint. I guess it's worth noting here that you've got the fibular and tibular nerve that are innervating many of these muscles. The plantaris is the plantar flexes at the ankle and flexes the leg at the knee joint, and its innervation is the tibial nerve. The deep posterior compartment of the leg, the popliteus, is going to flex the knee leg at the knee joint and medially rotate the tibia to extend unlock the extended knee. So again, maybe try doing these movements with your own leg. And then the innervation is going to be the tibial nerve. Tibialis posterior, plantar flexes the foot at the ankle nerve and it innervates and supinates the foot at the intertarsal joints. And the flexor digitorum longus, so the plantar flexes the foot at the ankle joint, flexes distal and middle phalanges of toes, and they at interphalangeal joints and the proximal phalanx of toes 2 through 5 at the metatarsophalangeal joint. And the flexor hallucis longus is a plantar flexus foot at the ankle joint, flexes distal phalanx of the great toe at the interphalangeal joint, proximal phalanx of the great at the metatarsophalangeal joint. Again, the innervation here is via the tibial nerve. So you'll recognize kind of again this pattern of innervation. Okay, muscles of the foot themselves. Okay, so once we get down into the foot, you can see here you have your adductor hallucis. Oh, wow, that's super thick. Oh, that's what's wrong. So your adductor hallucis, you can see here, your lumbricals, very similar to what we saw in the hand. Flexor hallucis brevis, flexor digitorum brevis, flexor digitorum brevis again, abductor hallucis again, you can see down here, abductor digiti minimum, abductor hallucis. Again, you're recognizing these muscles from different angles. Plantar interossi, so you can see the kind of how those muscles are located in a slightly different area. The flexor hallucis brevis, the flexor digitorum brevis, and then here's your abductor digiti minimum, kind of located here. You can see it's cut away, as well as the quadratus plantae, which is also cut away. And again, we've mentioned some of these muscles before, so hopefully this isn't overwhelming, and you're just kind of seeing them located in the foot themselves. The plantar interossi, here you can see 1 through 3, those muscles that are located there. And if we look at the dorsal interossi, 1 through 4, you can kind of see how those muscles are kind of located on those bones, just slightly different on those metatarsals, 1 through 5, just in different kind of orientations and locations. Okay, so the extensor hallucis brevis, it's going to extend the great toe at the metatarsal phalangeal joint. Its innervation is the deep fibular nerve. The extensor digitorum brevis extends the toes at 2 through 4 at interphalangeal joint. It's the deep fibular nerve. The adductor hallucis adducts and flexes the great toe at the metatarsal phalangeal joint. It's the medial plantar nerve. And the flexor digitorum brevis, again, flexing those toes 2 through 5 at the proximal interphalangeal and metatarsal phalangeal joints. The innervation is the medial plantar nerve. It's interesting to note here as we're going through many of these, some of the origins and insertions. The origins are going to be in regions like the calcaneus. Again, that's going to be probably more commonly known as your heel bone. So the abductor digitorum minimum, again, has that same origin, the calcaneus, and this is going to adduct, flexes the little toe at the metatarsal phalangeal joint. The innervation is going to be that linear plantar. Quadratus plantae, the origin is the calcaneus. Again, you see here a lot of muscles are kind of originating from that particular bone. Assists in flexor digitorum longus, and only to flex toes at the 2 through 5 at the interphalangeal and metatarsal phalangeal joints. And the lumbricals, we've kind of looked at the lumbricals into a couple of different angles here. Extend the toe 2 through 5 at the interphalangeal joints and flex toe 2 through 4 at the metatarsal phalangeal joints. And then if we talk about kind of the third layer into the foot, the flexor hallucis brevis, its action flexes the great toe at the metatarsal phalangeal joint. Adductor hallucis and flexor digitorum brevis, again, adducting and flexing the great toe, flexing the little toe. Adductor hallucis is working with the great toe. Flexor digitorum minimus brevis is going to be flexing the little toe. And they're both innervated by the lateral plantar nerve. And when we talk about those interossi, we looked at a really nice image of those interossi, showing kind of how they distribute differently on those metatarsals, or I'm sorry, no, metatarsal phalangeals. So the dorsal interossi, abducts flexes toe 2 through 4 at the metatarsal phalangeal joints and extends toes to the interphalangeal joints. And the plantar interossi adducts and flex proximal metatarsal phalangeal joints and extends toes at the interphalangeal joints. Again, innervation is via the lateral plantar nerve. Okay, deep breath. We have made it through the muscles. If you are still watching in a single sitting, wow, good for you. We are going to just quickly talk about some disorders of the muscular system. And then, yeah, I think there should be some disruptions to homeostasis here, but I'm not quite sure. So the first thing that they talk about is running injuries. Most running injuries are going to be involving the knee or lower region of the body, sometimes the back. Usually it's related to some type of faulty training. This is probably something, again, physical therapists probably deal with a lot. So if this is your interest, it's probably worth investigating this a little bit more. Can be treated via price, NSAIDs, or corticosteroid injections to reduce inflammation, or rehabilitative exercises, again, because the training technique and your form is so important. Small corrections in your form can actually probably go a long way in preventing injuries with running. Compartment syndrome is another issue that individuals might have. So you have pressure that constricts structures within the compartment, damaging the blood vessels that are vascularizing different muscular regions. So if you do not have blood supply going to those regions, nerves can suffer damage because they're not getting the blood supply and vascularization that they need, and muscles can develop scar tissue, and contracture may develop. And so you'll start to kind of lose function of some of those muscle groups over time. Plantar fasciitis, again, is a very popular issue that arises often in the lower limbs. It's a painful heel condition that results from chronic irritation of the plantar aponeurosis and its origin on the calcaneus. Again, thinking about your heel and the heel bone. The treatment includes ice, heat, stretching, weight loss, prosthetics, steroid injections, and/or surgery. Often when you're talking about muscles and recovery, people use kind of heat, ice, and reduce inflammation to assist in the rebuilding of muscle processes. We didn't get to talk about individual muscle structure, which is kind of unfortunate because we talk about how, muscles essentially repair themselves and how muscles are built back up. And so sometimes utilizing those therapies can be really advantageous to repairing muscles in a lot of ways. Holy cow, we made it to the end here. We did not get a chance to talk about the effects of muscles on homeostasis, unfortunately. However, we went through a lot of muscles today. So I'm going to be putting together an abbreviated list of places you should be spending more of your time. And again, origin insertion, not needing to know at this level of kind of understanding. Probably a bigger thing is just to kind of get a general sense of some of the larger muscle groups of the body. Probably won't get too into the weeds of the hands and feet just because there are a lot of muscles there. But again, I think getting that review sheet out to you is going to be very important. So if you have any questions or concerns, please feel free to reach out. And thank you everyone for your time and attention. And like I said, if you had to stop and maybe pause this every 20 minutes for like a couple different sittings, totally understand. Yeah, it's definitely kind of some dense material. So hope everyone has a wonderful day. And yeah, thank you so much for your time.